Diseases of nerves and muscles. So, as we know, there are a lot of nerves concerning our region, that is the oral and maxillofacial region. So, many diseases like the neuritis, neuralgias, and many syndromes occur because of disturbances in the nervous system, or because of inflammation, because of infections, because of malformations. So all these we are going to study. So basically, diseases of nerves, majorly the most important ones are the trigeminal neuralgia, which is the disturbance which affects the fifth cranial nerve, and the Bell's palsy, disturbance which affects the seventh cranial nerve, and the glossopharyngeal neuralgia, there is a disturbance which is affecting the ninth cranial nerve. And a lot of syndromes occur because of some damage to the nerve, or some degeneration of the nerve, or because of some infectious process. So we'll see the major or important ones. The trigeminal neuralgia. Trigeminal neuralgia is nothing but neuralgia, nothing but pain of the nerve occurring along the distribution of the trigeminal nerve. As we know, trigeminal nerve is a big nerve. Actually, it's a major nerve. It has three divisions. There is the ophthalmic, maxillary, and mandibular division. It is the fifth cranial nerve. It arises from the trigeminal ganglia, or the sensory root ganglia. So, trigeminal neuralgia is also known as tic douloureux, trifacial neuralgia, or Fothergill's disease. It's basically a neuralgia affecting the trigeminal nerve. So, why it is called as tic douloureux? Tic douloureux, whenever the trigeminal neuralgia symptoms, they are associated with contractions of the facial muscles, that is the spasm of facial muscles. That time it is known as the tic douloureux. Trifacial neuralgia, because it is affecting the two divisions of the maxillary nerve, that is basically the maxillary and the mandibular divisions, and few times the ophthalmic divisions. Majorly only the maxillary and mandibular divisions of trigeminal nerve show clinical manifestations. So trigeminal neuralgia, it's characterized by extremely severe electric shock like lancinating pain along the distribution of the trigeminal nerve. So the pain is very severe, it's electric shock like, and the pain is unbearable to the patient. And though the pain lasts just for few seconds, it has such an effect on the patient that he constantly lives in the fear of pain. So he'll be in fear. So the associating when the attack may occur, because the attacks are like uncontrollable. They may persist just for few seconds. So we'll see the clinical manifestations of the trigeminal neuralgia. Overall incidence of trigeminal neuralgia is 1 in 6 lakh, or 1 in 1 lakh individuals. 6 in every 1 lakh individuals. Okay, so not that common, but whenever it occurs, it is very severe in nature. So what is the cause for trigeminal neuralgia? Most of the times, idiopathic, the cause of inflammation of the nerve is not known. Sometimes there is some peripheral damage to the nerve occurring either because of some inflammation of the nerve or some tumor. It's causing damage to the nerve, thereby giving rise to this condition. Or some disease of the trigeminal nerve, or some infection affecting this. Tumors, basically they give rise to this, or the compression of the trigeminal nerve because of some bony structure as tumor. So that gives rise to this symptoms of neuralgia. So trigeminal neuralgia, it basically affects middle-aged or older-aged individuals above 40 to 50 years, like that. It starts only after 35 years, and females are more commonly affected than men. And this neuralgic pain has a tendency for occurring more commonly on the right side of the face when compared to the left side. So what are the characteristics of pain? So neuralgia, as we know, it's associated with pain along the Now, so what kind of pain is seen? The pain is basically very severe, electric shock like stabbing, lancinating and searing type of pain. So such words give an indication of the intensity of the pain. So the frequency of attacks just varies. You never know when you get the attack. But the duration of the pain is just for few seconds. So where the pain starts whenever patient touches the trigger zone on the face. The trigger zone is nothing but the area which is supplied by the trigeminal nerve. So that area when stimulated gives rise to this neuralgic pain. So the trigger zones in the orofacial region are nothing but the vermilion border of lips, the ala of nose, the cheeks and around eyes. So these patient learns that whenever he touches that particular trigger zone, the attack is initiated. So he just learns to avoid touching that particular area. Not only touching, just a strong breeze of air is enough to initiate the neuralgic pain. So initially, in the early stages of the disease, the pain used to be very mild. So how the disease starts? So the patient has just a dull, boring, aching pain resembling dull, boring or sharp aching pain resembling that of a toothache. As the disease progresses over years, then the disease becomes severe, electric shock like pain is seen. So there are long asymptomatic refractory periods between the attacks. That is, the attack occurs today, and for many years again the disease remains quiescent. There is no attack is seen. Then suddenly the attack reappears. So that's the characteristic of trigeminal neuralgia. Then whenever the attack occurs, the patient becomes extremely irritable, extremely ill, and he clutches his face in as if in terror of pain, and the attack just lasts for few seconds. And he learns to avoid touching the trigger zones. So the patient frequently doesn't wash his face, or in case of males, they go unshaven. So the disease, the characteristic feature of trigeminal neuralgia is that the neuralgic pain, suppose it's occurring on the right side of the pain, right side of face, it doesn't cross to the left side. So it is unilateral in distribution. So we have seen the clinical features of trigeminal neuralgia. So treatment for trigeminal neuralgia, initially the peripheral neurectomy or division of the nerve was carried out. Then injection of alcohol into the peripheral nerve. So this give symptomatic relief to the patient from the symptoms. Then surgical sectioning of trigeminal sensory root of the trigeminal sensory root, basically from where the sensations are arising. That sectioning of that nerve also gives rise to relief from the symptom permanently. Then coming to the medications, phenytoin and carbamazepine has been used. The carbamazepine drug has a feature that it relieves the neuralgic pain within 24 hours. So it has also been used as a diagnostic criteria for differentiating trigeminal neuralgias from other forms of neuralgia. So once when the patient, you have suspected trigeminal neuralgia and have put on carbamazepine, you should have rapid relief of symptoms within 24 to 48 hours. If no relief of symptoms is seen, then your diagnosis of trigeminal neuralgia has to be re-evaluated. So that's with trigeminal neuralgia. Now we'll see the other common neuralgia, that is the spinopalatine neuralgia. Spinopalatine neuralgia, it's affecting the median nerve, basically, according to an author. It's affecting the median nerve. That's why it's also known as the median nerve neuralgia, or the Sludder's headache, or the cluster headache, because of cluster of symptoms of neurological symptoms, that is headache, facial pain and all are seen. That's why it's called a cluster headache, and also known as the Horton's syndrome or the alarm clock headache also. So basically the etiology of spinopalatine neuralgia is not known, but there appears to be a periodicity. That is, whenever the hormonal levels are elevated, hypothalamic hormonal levels, At that time, there is an increased incidence of this neuralgic pain. And this neuralgic pain is seen in the middle-aged individuals with male predilection, whereas trigeminal neuralgia had female predilection. And when you see the clinical features of the disease, you see that unilateral paroxysms of pain occur in the region of eyes, maxilla, ear, and zygoma. And these pains have no trigger zones, no associated trigger zone is present, and the pain lasts for from few minutes to few hours. In trigeminal neuralgia, the pain was just for few seconds. So that's the differentiating feature. And another interesting point is the headache. It begins as a headache or pain in the region of this eyes and maxilla, right? So whenever the pain occurs, it has a tendency for occurring at the same time of the day every day. So that is related to the hypothalamic hormonal periodicity. So since it's occurring at the same time every day, it's also known as the alarm clock headache. And the time period between two attacks is extremely variable. So the patient may be symptom free for months to even years. Or whenever it's occurring with periodicity, it may be continuous daily at the same time. And along with the associated pain in the orofacial region, you have a swelling of the nasal mucosa, nasal discharge, and watering of the eyes, also known as epiphora or bloodshot eyes. So these are the features of neuralgic pain, also known as the headache, cluster's headache. So the cluster of symptoms along with the pain in the orofacial region, so that's why it's also known as a cluster's headache. Treatment for this include cocainization, that is injection of cocaine drug into the spinopalatine ganglion, or medically you can use ergotamine. It provides serotonin inhibitor ergotamine, which provides rapid relief from symptoms. Then these were the neuralgias. Now we'll see a syndrome associated with the damage to the nerve. That is the auriculotemporal syndrome. It occurs because of damage to the auriculotemporal nerve. It's also known as Fraze syndrome or gustatory sweating. Gustatory sweating, as the name suggests, it shows increased sweating. So how? We'll see. Auriculotemporal syndrome, it arises because of damage to the auriculotemporal nerve initially. This damage may occur because of any form of tumor or during surgical operation. If suppose the nerve is damaged, after this damage is repaired by regeneration by the parasympathetic nerve supplied to that area. So damage has occurred and it has been repaired by the parasympathetic nerve supply. That nerve supply, it innervates the sweat glands in case of this syndrome. So that gives rise to this auriculotemporal syndrome. So parasympathetic nerve supply, whenever it innervates the sweat glands, so it's, whenever the area is stimulated, so it leads to increased sweating. So clinical features of the auriculotemporal syndrome are nothing but flushing of face or increased sweating, facial sweating, as well as the perioral sweating only on the involved side of the face. Whatever side the auriculotemporal nerve is damaged, that side it shows innervation by the parasympathetic supply to the sweat glands. So that area shows increased sweating and facial flushing. Whenever patient eats spicy foods, the sweating, there is increased spicy foods and mastication is taking place, then there is increased sweating of the involved side of the face, and bloodshot eyes, also known as the crocodile tears, that is increased watering of eyes is noticed. Why? Because when the damage is repaired by parasympathetic nerve, there appears to be a synkinetic response between the autonomic nerves and the lacrimal nerves. So both of them fuse together and give rise to this sweating and lacrimation, whatever we are seeing. Okay, sweating features along with the lacrimation. Treatment for auriculotemporal syndrome is nothing but division of the auriculotemporal nerve. So whatever nerve has regenerated leading to a synkinetic response, that is just divided, giving rise to rapid relief of symptoms. So other common disturbance which affecting the 7th cranial nerve or the facial nerve is the Bell's palsy. Bell's palsy is nothing but facial paralysis. It is abrupt, isolated, unilateral peripheral facial paralysis without any detectable causes. So etiology is not known, it is idiopathic. Few of the authors have attributed it to increased incidences of herpes simplex virus infections or damage to the facial nerve or inflammation of the facial nerve with resultant edema, which causes nerve compression when it passes through the bone, and that leads to facial paralysis. And during surgical removal of few of the tumors also, if the nerve is damaged, it leads to features of Bell's palsy. Bell's palsy, the characteristic features are that it occurs more frequently in spring and fall, autumn seasons of the year, and it has a predilection for occurring in women. Initially, you can see whenever the involved side of the face, it shows the paralysis of the facial musculature. So there will be drooping of the corner of the mouth, and there will be increased watering of the eyes. The patient will not be able to close his eyes or blink, will not be able to whistle, and the involved side of the face, the mouth just droops off. So the saliva just drools off that area, and whenever the patient smiles, the area of face which shows paralysis does not show any symptoms. So even if he smiles, the face is just drooping down, the corner of the mouth doesn't rise, the eyebrows don't raise, and the skin of the forehead also it doesn't raise. So the patient, typically the affected side, it shows mask-like appearance. So here in the clinical picture also you can see the symptoms that the right side of the patient, he's showing that the patient is actually smiling, but there is paralysis of the facial musculatures on the right side. You see the forehead, the skin does not raise, even the eyebrow is not raised, even there is drooping of the corners of the mouth. If you ask the patient to close his eyes, he won't be able to close. Diagnostic test for Bell's palsy is you ask the patient to blow the whistle, and he won't be able to blow the whistle. There is no specific treatment for Bell's palsy as such, but you can control the symptoms by because of increased watering or because of inability to close the eye, the corneal ulceration, more chances of corneal ulceration are seen. So you have to take proper care of the eye by keeping it hydrated, using lubricants and all. And use of vasodilator drugs such as histamine keeps the disease under control. And administration of physiologic flushing doses of nicotinic acid, all these keep the disease under control. So initially the Bell's palsy, it used to just start as a facial paralysis in the spring and just persist for a few days or few months and then regresses. But few of the cases it has been shown that it is because of paralysis of the facial nerve, and it leads to permanent symptoms of facial paralysis. When surgically it has been damaged, so the lifelong patient suffers from this form of palsy, Bell's palsy. Then glossopharyngeal neuralgia, it is another uncommon lesion affecting the 9th cranial nerve. Here the pain is very severe and excruciating, similar to the trigeminal neuralgia. As we have seen, the pain is very severe. Here the glossopharyngeal neuralgia, it is seen in cases of middle-aged or older individuals, and the pain is of same as in trigeminal neuralgia, sharp shooting pain in the ear, along with characteristic of glossopharyngeal neuralgia, that is pain in the pharynx, nasopharynx, tonsil, and the posterior portion of tongue. So patient has difficulty in eating, swallowing, dysphagia is noticed, and whenever patient just indulges in the normal habit of eating or swallowing, neuralgic pain starts off as severe sharp pain. So that indicates that there is some trigger zone in the tonsillar region or the posterior portion of the tongue. So the pain also, which is characteristic like that, it is unilateral in distribution. So even the simple act of talking or yawning or coughing or swallowing start the pain. Yeah, trigger zone is located in the tonsillar fossa or the posterior oropharynx. So this neuralgic pain is also very severe. Treatment for this includes the resection of the extracranial portion of nerve. Etiology for this is unknown. Etiology for glossopharyngeal neuralgia is unknown. So other idiopathic disease affecting the nerves is the multiple sclerosis. It's actually an inflammatory disease affecting the nervous system, central nervous system. It is a demyelinating inflammatory disease. So myelin sheath is just degenerating because of inflammation here. Multiple sclerosis, it's an autoimmune process. As we know, autoimmune means the patient develops antibodies to his own cells. So more damage occurs. And multiple sclerosis is seen in patients younger than 20 years of age or sometimes older than 50 years. So there is wide age range, and it is a more predilection for females. So since this is a demyelinating inflammatory disease, a lot of systems are affected here. And Charcot's triad is the diagnostic criteria for identifying this multiple sclerosis. Charcot's triad is nothing but a triad of symptoms, that is the intention, tremor, and nystagmus and dysarthria. That is, patient has difficulty in speech, and the eyes shows characteristic inability to concentrate on a single point, and tremor of speech, that is denoting the muscular weakness. So the triad of intention, tremor, nystagmus, and dysarthria is characteristic of multiple sclerosis. So it's an inflammatory disease. It affects the eyes. In severe cases, vision impairment, retrobulbar neuritis, and diplopia or inability to concentrate or difficulties in vision are encountered. And when you see the muscular system, generalized weakness, fatigability, and ataxia, that is inability to walk or maintain the gait, is seen. And there is extreme stiffness of all the extremities. So as the disease progresses, the patient has mood deviation towards cheerfulness. In cases of few other diseases, you can see the patient's deviation will be towards sorrowfulness. But in multiple sclerosis, it's the mood deviation towards cheerfulness, and there is loss of sensation of the affected area, that is the limbs, whatever are showing extreme weakness and fatigability. There is just loss of sensation in that area, and bladder retention and urinary incontinence are seen. So migraine, as we know, the commonest disorder affecting a lot of children or young adults is the migraine syndrome. Actually, as we all know, that migraine is synonymous with headache. It's a headache, but with a vascular quality, that is increased ischemic response because of vasoconstriction of blood vessels. The headache is of extreme severe in nature. So what is migraine? Migraine syndrome, it is characterized by vascular headache along with photophobia, sleep deprivation, and in extreme cases, depression also. So what is the etiology of migraine? Migraine arises because of vasoconstriction induced ischemia. The headache, whatever is occurring, it is actually a hyperemic response to vasoconstriction of blood vessels. leading to throbbing quality of headache. The headache is of such severe nature that the patient just is unable to bear the pain and the symptoms caused by it, and he is extremely weak, extremely irritable, extremely lethargic. So this migrainous headache, it's more commonly in women, that too in the second decade of life. So this is the syndrome affecting the younger generations, usually in the second decade of life. So initially, before even the headache starts, hours before or one day before you start to see the prodromal symptoms, that is the weakness, lethargy, fatigability, extreme irritability, and just few hours before the onset of headache, the patient shows visual disturbances. He'll get hallucinations, photophobia, irritability on seeing the light. The patient just avoids the areas wherever there is focus of light. He just starts irritating when he sees the TV, and he feels uncomfortable on exposure to light, extreme light. And hallucinations, he just starts daydreaming like that, and visual disturbances arise few hours before. And at the time of onset of headache, the patient will be extremely irritable, he'll be confused, he'll be mentally disturbed, and he'll just lose the sensations. And this migrainous headache, basically it affects only the half side of the face, that is the unilateral. And once headache starts, it's accompanied by severe pain in the temporal, frontal, and the retrobulbar area. The symptoms persist as the attack starts, the symptoms persist for few hours to months. Then the face becomes pale, so the patient will be extremely weak. You just can make out from the face that he's in extreme trouble. And along with the headache, it has been associated with nausea, vomiting, and anorexia. So that explains the throbbing quality of the migrainous headache. So treatment for migrainous headache is nothing but, few of the times the occurrence of migrainous headache has been precipitated by usage of some food items or any irritant. It differs for varying individuals. Few individuals may have some form of irritation to any food items, or few individuals, they have irritability on consuming alcohol or consuming tea. So they may be the precipitating factors for this migrainous headache. Or treatment for this includes the anti-inflammatory drug, that is the acetyl salicylic acid, commonly used one, and the codeine and the ergotamine. So whatever we do, identifying the irritant helps prompt relief in few of the cases. And few of the cases, the migrainous headache may have to be treated for a long period of time. Maybe the treatment may take place for months or even years without any relief of symptoms, because the attack will occur when it has to occur. Other thing we'll see about the inflammation of artery, that is the temporal artery. Whenever it is inflamed, it gives rise to a severe pain like condition. So this is nothing but the temporal or gain cell arteries. Basically, it is a focal granulomatous infection occurring in the temporal artery. So whatever the region is distributed by that particular artery, it shows symptoms or clinical manifestations. So etiology for this is basically a disease of cellular immunity. So there is activation of CD4 T helper cells, and that leads to production of factors which are responsible for causing this inflammation or inflammatory mediators. And this disease is basically seen in older age individuals, that is about above 50 years of age, and it has a predilection for occurring in women. So initially the onset of pain, the temporal or gain cell arteritis, it is associated with headache along with muscular weaknesses, and inflammation occurs inevitably. So what kind of headache is seen? The headache is basically very slowly progressing one. It's insidious in onset, it's sudden, and whenever it occurs, it is just of burning quality or a throbbing type of pain. It's unilateral only, just restricted to the area of distribution of the temporal arteries. And prodromal symptoms before the headache are malaise, chills, fever, weight loss, anorexia, vomiting. All prodromal symptoms denote that the person has become lethargic or weak. So once the prodromal symptoms are noticed, then headache of vascular quality, headache begins to start. Then you can see that muscles of shoulder and hip especially, they become stiff and very, very weak. That's nothing but polymyalgia rheumatica. When the masseter muscle is affected, it shows that the jaw is become fixed or rigid. That is nothing but the jaw claudication. This jaw claudication leads to difficulty in chewing or swallowing, and the pain, it is distributed along with headache. You see the pain is distributed to the teeth, the temporomandibular joint, the scalp, and the jaw claudication occurs, right? So whenever you just start eating something or swallowing something, you just initiate the pain. So this all these symptoms of pain or along the distribution and the inflammation and the stiffness of muscles, whatever we are seeing, it is because of the inflammatory release of inflammatory mediators and spread of inflammation over the swollen tortuous arteries. And characteristic eye pain or photophobia or blindness is seen. So temporal or gain cell arteritis, the clinical manifestations are seen wherever there is the distribution of the artery. That is the facial muscles, the jaws, the eyes, and the headache. And lab diagnosis is the erythrocyte sedimentation rate here is elevated. And when you see the clinical microscopically, when you see the region of inflammation, you can see that there is proliferation of intimal blood vessels, and we know that blood vessel has tunica media, tunica elastica. So the tunica media, whatever is there, it is completely necrosed, and the tunica elastica or the internal elastic lamina, it is disrupted, it's showing inflammatory features, and gain cell or multinucleated gain cells are seen with chronic inflammatory cell infiltration. So that is the histologic picture of gain cell arteritis. Treatment for this includes relief of symptoms symptomatically by providing anti-inflammatory drugs. Then there is other common syndrome, other commonly affected neurological conditions seen after the extraction of tooth. That is nothing but the complex regional pain syndrome or causalgia. It is more common. Actually, few of the patients have reported severe pain in the region after extraction of a multi-rooted teeth. So after extraction, within a few days or weeks, the patient reports severe pain in the area of extraction without any detectable dry socket or any other form of inflammation. Clinically, you can see that the area is healing correctly, but the patient complains of pain, severe pain in that region. Because of injury, inevitably injury has occurred. You are extracting a tooth, so trauma is there, injury is there, but the response given by the patient is not in accordance with the trauma encountered. So causalgia is seen at any age, and mostly it is reported with extraction of teeth, and the patient complains of a pain which is of burning quality, which is extremely severe, incapacitating in nature, or unable to bear like that. And pain develops at the site of injury only, and usually what happens, whenever you notice pain, it has to be relieved on application of heat or cold. But here the pain is becomes severe on application of either the heat or cold, and this condition, few of the authors have reported that the trauma during extraction may not be that severe to cause pain of very severe quality. So this causalgia has been attributed to neurological manifestation of the patient, that patient is just attributing the pain to the extraction, and it's just a neurological manifestation like that. So treatment includes nerve block. Just a nerve block into that area relieves the patient of symptoms rapidly, and then phenol cauterization and injection of procaine into the particular area provides rapid relief of symptoms. So because the etiological factors and the clinical manifestations both are not specific, it has been called a complex regional pain syndrome and located at the site of injury. So atypical facial pain or atypical facial neuralgia is a neuralgia without any specific cause. No identifiable etiological factor is attributed to the pain, which is unanatomic. There is no particular restriction that pain is occurring in the region of maxilla. Like, pain is just unanatomic in distribution, occurring anywhere along the face or eyes. And up till now we have seen whatever the migraine or the temporal gain cell arteritis, all are unilateral. That is, they are just the pain is distributed along the distribution of nerves, arteries, or it is just restricted to one side of the face. But atypical facial neuralgia, the pain is just unanatomic, and it crosses the midline, and it is diffuse in nature. Actually, atypical facial neuralgia, it constitutes a group of conditions where there is deep, localized, poorly localized, and deep pain which is vague in nature, and just, it appears to be supplied, the regions appears to be supplied by the 5th cranial nerve, 9th cranial nerve, and 2nd and 3rd spinal cervical nerves. So this pain is unanatomic. It is atypical in distribution. There is no specific cause. The pain crosses the midline, and here even the pain, there is no specific trigger zone, and the pain, if present, it persists for months, weeks, or even years sometimes. And if sometimes it has been attributed that the pain is occurring in the distribution of maxillary or mandibular division of trigeminal nerve, that is in the facial region, it has been attributed. But it is differentiated from trigeminal neuralgia in that the pain is not unilateral, it crosses the midline here. So the treatment includes the tricyclic antidepressants, phenytoin, and carbamazepine. There are a few other syndromes which denote pain in the facial region, that is the Eagle syndrome. Eagle syndrome, it occurs, the etiology for Eagle syndrome is the pain, that is the elongation of styloid process, or we know that normally there is a styloid process occurring. If it is elongated and it leads to impingement on between the internal and external carotid artery, it shows the features of pain distributed to the area of facial region, along with headache, dysphagia, and soreness of throat, and vague orofacial pain basically. So etiology is the elongation of styloid process and the ossification of styloid ligament, and patient complains of inability to swallow, inability to speak, or inability to eat, and pain is because of impingement of the styloid process along the distribution of external and internal carotid nerves. Impingement of styloid process leads to this syndrome known as Eagle syndrome. And Horner's syndrome. Horner syndrome is also known as sympathetic ophthalmoplegia. It is basically a triad of meiosis. Meiosis is nothing but the contraction of pupil of eye because of the muscles present there. They are showing paralysis, so the pupils of eye contract. Then ptosis is nothing but drooping of eyelid because of the paralysis of muscles, that is the elevator palpebrae. Then you notice anhidrosis and vasodilatation. These are occurring because of interruption to the secretomotor and vasomotor control. Etiology for Horner's syndrome is some form of lesion or tumor in the brainstem or infections occurring, which leads to this triad of meiosis, ptosis, and anhydrosis. There is other common syndrome which is seen in infants, the Marcus gun jaw winking syndrome. It is also characterized by unilateral ptosis, that is inability to close the eye on one side. Along with ptosis, there is elevation of ptotic eyelid to the on the movement of mandible to the contralateral side. So this Marcus gun jaw winking syndrome is most commonly noticed by the mother when on breastfeeding. The infant shows inability to close the eye on one side, and when the infant is just turning his head to one side, there is elevation of the eyelid, ptotic eyelid. So etiology is some form of injury either during delivery or birth or after some minor trauma. So males are affected more commonly, and left upper eyelid is more commonly affected. So that's about the Marcus gun jaw winking syndrome. There is another inverted form of Marcus gun jaw winking syndrome, also known as Marie-Nanette syndrome. So these are the common syndromes affecting the nerves or nerve supply, showing inflammation, degeneration, and all. Burning mouth syndrome, actually it's a complex disease affecting the oral mucosa. Here the burning mouth syndrome, it affects basically the patients, and patient complains of burning, quality of pain, stinging of oral mucosa, either the buccal mucosa, lips, tongue, or palate, whatever region. It is showing extreme pain and burning in the region without any associated reason for the cause, that is without any associated inflammation. So, and without any visible mucosal lesions in the oral cavity. Predilection for occurring in women, and most commonly it has been seen in postmenopausal women, that is the age of onset is after 50 years, and without any visible inflammation or ulcer or any mucosal lesion. The patient gives a history of burning, quality of pain, inability to eat the food, inability to drink or swallow, or the pain is of burning quality, that is there is no relief from symptoms whatever the patient is trying. And if you can clearly see, you can see that the few local and systemic factors underlying the disease process. So there is presence of a dry mouth or xerostomia. It has been attributed to extreme dryness of oral mucous membrane leading to the burning quality. Then some form of trauma to oral mucosa, or tumors present tumor pathogens present in the oral mucosa, or some disorders like lichen planus or pre-malignant lesions present, or geographic tongue, which denotes inflammation. And patient may have systemic deficiencies, nutritional deficiencies, or hormonal deficiencies. Like the patient is menopausal, right? So there is estrogen insufficiency, and the psychogenic disorders or chronic diseases like the diabetes mellitus. And clinical features: when you see a patient, the patient is complaining of burning quality, burning pain in the oral mucosa along the tongue, lips, and the gingiva. And the pain may be continuously present throughout, and there is no point where the patient is free of symptoms. So, and the associated presence of dry mouth is invariably present. And patients are extremely depressed or anxiety. Patients have extreme anxiety, the mood swings are there, and patient complains of altered taste sensation, most commonly of bitter or sour taste in the mouth. Treatments for burning mouth syndrome includes identifying the cause. The postmenopausal woman is there, so hormone replacement therapy has to be carried out. So if xerostomia is the cause, anti-xylogogues have to be given, along with introduction of xylitol gums to just keep the oral cavity stimulated all the times, and antidepressants, vitamin and dietary supplements have to be substituted. So now we will see the diseases affecting the muscles. Most commonly the muscular system, it shows generalized deficiency, whether it is an atrophy, degeneration of muscle, hypertrophy, or enlargement of muscle, whatever it is. Generalized skeletal manifestations are more common. When coming to the oral cavity, mostly the facial musculature or the jaw muscles are affected. So we'll see what are the diseases of muscles. They are nothing but the dystrophies, that is the degeneration of muscle fibers, then the myotonia, that is reduction in tone. Though muscle is of normal size, there is the problem in contraction and relaxation of the muscle fibers. Then there is hypotonia, reduction in tone, and myasthenia gravis, it's an inflammatory condition. Myositis is also an inflammatory condition. So we'll see them one by one. Dystrophy, among the dystrophy, severe generalized muscular dystrophy is the most commonest one, also known as the pseudo-hypertrophic muscular dystrophy of Duchenne. So if we see the term pseudo-hypertrophy, so it's denoting hypertrophy, enlargement of the muscle initially, which is not true in nature. So there is some cost to it, right? So hypertrophy, then along with that muscular dystrophy. So you can see the symptoms of both the hypertrophy and dystrophy, that is degeneration of muscle, enlargement, which is false in nature, and degeneration of muscle fibers. So how we are going to see them both, we'll just study it. So this Duchenne dystrophy, it begins in early childhood only. The patient has inability to walk or run. When he'll be learning to stand, he'll be like unable to stand properly. So this is a rapidly progressive muscle disease. So it begins in childhood before the age of 6 years, and it may not be seen if the patient has crossed the age of 15 years. And so initially males are affected more commonly, and learning disabilities, there is inability to walk is seen. That's because of enlargement of muscles. Muscular enlargement or hypertrophy, whenever it's occurring, it leads to weakness of musculature, that is fatigability. It accounts for the fatigability of muscles. So in pseudohypertrophic muscular dystrophy of Duchenne, initially muscular enlargement occurs, and then as the disease progresses from childhood to young adults, atrophy of muscles is seen when the limbs become flaccid and weak. So when you see a microscopic picture, you see that there is a disappearance of muscle fibers. The muscle fibers are lost and they are replaced by the connective tissue and fat. So in the muscle you can see fat depositions or globules of fat are seen. So then lab diagnosis includes the elevation of serum creatine phosphokinase levels. So this disease, once it begins in childhood, there is no specific cure for this disease. Only thing is proper care has to be taken, support has to be given when the limbs become flaccid or weak. It is incurable. Myotonia, diseases of muscle. Myotonia is failure of relaxation after cessation of voluntary contraction. That is, whenever muscle is put into action or whenever it's contracted, after contraction it has to relax back to its original position. If there is a failure of relaxation of muscle, the muscle becomes hypertrophied or atrophied, or it just loses its function if there is no relaxation. Both the contraction and relaxation should occur simultaneously for the muscle to be in function. So there is failure of relaxation. So either atrophy or hypertrophy or degeneration or dysfunction of muscles will be seen. So myotonia we are studying basically three types of myotonia. So the dystrophic myotonia, the congenital myotonia, and the acquired myotonia. Dystrophic myotonia, as the name suggests, dystrophy, there is complete degeneration of the muscle. The muscle fiber show complete degeneration or dystrophy. So what happens? How the disease starts? So the dystrophic myotonia is familial. It is transmitted from generation to generation. It is characterized by weakness of muscles of face, jaw, and even the neck. So initially, this disease, dystrophic myotonia, begins with atrophy of the face, atrophy of musculature of face, that is the masseter muscle, and the sternocleidomastoid muscle. So as the muscles are atrophied, the patient gives the appearance of a swan neck appearance. That is, the neck appears to be, the jaw is fixed, and even the neck appears to be fixed like that. And along with the atrophy of muscles, there is ptosis of eyelid. That is, because of paralysis of the muscle, the eyelids are not able to be closed. Eyelids tend to be open. And because of the atrophy of masseter, the lower half of face appears to be narrowed, fixed jaw like that. And atrophy of all the facial musculatures is seen. That is, the weakness of pharyngeal musculature, laryngeal muscles is also seen. This leads, this contributes to the nasal voice, the dysphagia. And testicular atrophy is also seen because of degeneration. Histologically, you can see the presence of a large muscle fiber with a centrally placed nuclei. There is no treatment for this disease. It is also incurable one, and you can just but the patients lead a normal quality of life here, and only the orofacial musculature when affected, there is problems in eating or swallowing, and that has to be just corrected by giving symptomatic treatment or by just helping the patient in leading a normal life. There is no medical treatment as such for this dystrophic myotonia. Once it has once the disease begins, it just keeps on progressing. Ultimately, if it involves, the respiratory muscles, it may lead to contraction of the respiratory muscles, respiratory failure, and even death also. And the congenital myotonia. Congenital, as the name suggests, it is present from the time of birth, also known as Thompson's disease. So the dystrophic myotonia was associated with atrophy, right? Here the congenital myotonia, it is associated with hypertrophy of the muscles. The muscles are enlarged, they show enlargement. So this disease, it begins in early childhood, and the patient has difficulties in standing. He'll be like unable to walk. Disease is in childhood, so the child is unable to just walk or maintain the gait, so is ataxic. And the muscular contraction, there is failure of relaxation after contraction. This contributes for the spasms, that is painful muscular spasms. So when you see clinically the generalized body, it shows that hypertrophic appearance. So the arms, the forearms, the thighs, they show hypertrophy of muscles, the increase in size. That contributes to the Herculean appearance. So Herculean appearance is nothing but the muscles become larger, hypertrophic there. And if there are spasms of extraocular muscle, it leads to presence of convergent starbismus, that is inability to close the eye or inability to concentrate on an object. When you see microscopic picture, you can see enlarged muscle fibers, that is hypertrophied muscle fibers, and there is no specific treatment for hypertrophy as such. Acquired myotonia. Acquired myotonia is nothing but the spasms of muscle after contraction. That is, whenever a muscle is put into action, it is not relaxing back. So that's contributing for this spasms. The spasms may range from just mild twitches of the muscle to very severe painful muscular cramps. So the term clonus is used when there are spasms are intermittent, very seen at regular intervals. So that is known as myoclonic contractions. The term trismus is applied when the spasms are constant in nature or present for a longer duration, also known as the myotonic contractions. Myoclonic contractions intermittent. Myotonic contractions are constant. So that's with the myotonias or defect in relaxations. Now we'll see hypotonia. Hypotonia is nothing but reduction or complete absence of tonus in muscles. Tonus is nothing but the strength of the muscle. So though it present, it may be weak or defective quality, we can tell. So congenital disorders mostly show this hypotonia. There is the Down syndrome, it shows hypotonia. With the monogolic features, the child just shows the characteristic hypotonia of muscles, short stature and all. Then cretinism, defect in calcium metabolism also shows the features of hypotonia, because you need calcium complex for the muscle activity to progress normally. And in cases of achondrodysplasia and infantile cortical muscular dystrophy, infantile muscular dystrophy, neonatal myasthenia gravis, all these conditions show reduction in tonus of muscles. So the muscles are relatively weak and there is a reduced tendon reflexes. So we'll study the other common disorder which is affecting the muscle, that is the myasthenia gravis. Myasthenia gravis is basically autoimmune disorder. What is meant by autoimmune? Autoimmune is nothing but development of antibodies, autoantibodies by the patient. Here in case of myasthenia gravis, antibodies to acetylcholine receptor are developed at the neuromuscular junction, and that leads to this disease, that is the myasthenia gravis. It is characterized by weakness of skeletal muscles and extreme fatigability on exertion. Whenever you put the muscle to use, it shows exertion and weakness. So as we see, etiology is nothing but autoimmunity. So it is more common in middle-aged individuals and has a predilection for women. So how the disease begins? The disease begins with weakness, rapidly progressing weakness of the muscles. So the characteristic of this myasthenia gravis is the ptosis of eyelid. That is, the eye is unable to be closed. It affects one eye. So ptosis of eyelid may be seen along with dropping of face. That is, the muscles appear to be fixed. There is no characteristic facial expression by the patient. So the characteristic sorrowful appearance. So it gives him the sorrowful appearance. And the muscles of orofacial region, that is the jaw muscles, are affected. The speech is slow and slurred speech, and the patient has difficulty in mastication also. So the clinical picture of ptosis is seen, and yeah, you can just make out how the sorrowful appearance of the face is seen because of the ptotic eyelid. And so the speech is slow, and the head, it cannot be held because of the extreme weakness of the muscles. The head cannot be held high without any support. And the patients, as the disease progresses, the muscles, normally we tend to walk and do a lot of things. With each voluntary activity of our muscles, the muscles become further weak. So that the patient loses weight and further become weakened. Inevitably, the contraction or the weakness of respiratory muscles occur, ultimately leading to death of the patient. And when you see microscopic picture of the myasthenia gravis, you can see the atrophy of muscle fibers and focal collections of lymphocytes. Treatment, because it's an autoimmune disease, a lot of treatments have been tried, but symptomatic relief is being provided by the physostigmine drug. Myositis, it's also known as inflammation. Myositis, that in term itself indicates that there is some inflammation of muscles. This inflammation, it may lead to a variety of conditions or syndromes, we'll see the heterotopic ossification. Ossification is nothing but deposition of osseous tissue. Okay, it may be myositis ossificans progressiva or the traumatic myositis ossificans. Inflammation or deposition of osseous tissue or bone, it occurs because of either because of trauma or some form of inflammation. We are studying the myositis ossificans progressiva condition. Okay, it's a form of heterotopic ossification. Heterotopic ossification is nothing but deposition of osseous tissue in conditions where it is not normally seen. If we see a muscle fiber, we cannot see any osseous tissue in a normal muscle fiber. In this condition, myositis ossificans progressiva, you can see deposition of osseous tissue or bone in the muscles. That is the characteristic feature. So it's basically seen in young children. It is initially the muscle shows development of soft fluctuant masses or nodules. Painless in nature, the nodules develop anywhere along the body, and the nodules are like soft in nature. They are painless and characteristic. The skin will be little bit inflamed or red in color. This nodules can be seen around any of the skeletal muscles. So entire group of muscles, they show ossification, deposition of osseous tissue, and the entire muscle is being transformed into bone. It becomes just fixed. Once the ossification of the muscle begins, it becomes fixed, and there is limitation of movement of that particular joint. If coming to the orofacial musculature, if the masseter muscle is involved and ossification occurs in that particular area, the jaw appears to be fixed, giving the individual the appearance known as the petrified man appearance. Once, just imagine, muscle is a soft tissue. Once it is being replaced by a bone, it becomes a bony like a thing. So where is the movement? There is no movement. Fixed. It's fixed, called as petrified man. And when you see a microscopic picture, you can see that muscle is gradually replaced by connective tissue, and there is deposition of osseous tissue, ossification occurs, and there is no treatment for this condition. It is an incurable and not even symptomatic relief can be provided. So once the disease occurs, it's just progressive, like that. Mobius syndrome, also known as a congenital facial dysplasia, it's occurring in children, it's an inherited disorder. It's characterized by facial paralysis along with congenital facial paralysis along with inability to close the eyes. Usually facial paralysis along with ptosis or inability to close the eye is the characteristic feature. Here if you see the clinical picture of the individual, he is showing diplopia and everted lips. Okay, he is not able to close his lips. Thus the mouth remains partially open, and this disease is usually seen in infants, may not be noticed at the time of birth, may be seen few months after the birth, and the child is just unable to close his eyes during sleep. Yeah, it will be noted by parents that the patient is just not closing his eyes even during sleep. The eyes remain partially open, even the mouth remains open. And there is deformity of ears, the diplopia is seen, and there is paralysis of tongue. The tongue is not under control, it shows paralysis. There is deformity of ears also, external ophthalmoplegia, and slightly the child is mentally retarded, and presence of clubbed foot is seen. And along with mental retardation, the patient has features of epilepsy. So all these are disorders which are affecting the muscular system. So we have seen the diseases affecting the neuromuscular system, both the nervous system and the muscular system, along with their characteristic orofacial manifestations.